Hello everyone, my name is Karen Chung. I am with the Lewin Group and we are supporting the Medicare-Medicaid Coordination Office in the Centers for Medicare and Medicaid Services to ensure that dually eligible beneficiaries have access to seamless, high-quality health care. Next slide, please. Great. Before we get started, I want to go over a few pointers for using this webinar platform and to help you troubleshoot any technical issues. First, the audio portion of the presentation will automatically stream through your computer speakers. So please make sure the volume is turned up on your speakers so you can hear the presentation. We did send out phone dial-in information to the first 500 registrants for this webinar. But if you would like a phone line, you can go ahead and contact us at the number listed here. And if you're experiencing audio or technical difficulties, you can use the chat feature on the left-hand side of the screen and send a message directly to the moderators. Or you can call the number listed, 866-930-4500 for assistance. And also, I'd like to remind you all that microphones will be muted throughout the presentation, but there will be a question and answer opportunity at the end of the presentation. So again, if you have questions, go ahead and use that chat feature. We'll compile all the questions throughout the presentation, and during our Q&A, we'll ask those questions of our speakers. Next slide, please. This is the second webinar in our 2017 Meaningful Member Engagement Series. Today's session will include a 60-minute presentation from experts, including a beneficiary, followed by a Q&A discussion between you and the presenters. This session is being recorded, and a video replay, the slide presentation, as well as the question and answer will be available on our website at resourcesforintegratedcare.com. And if you'd like a copy of the slides from today's webinar, they're located in the upper black bar on your screen. You can click on the play button called the Media Library, and you'll be able to download the slides directly from the webinar platform. This webinar is presented in part by the Lewin Group and Community Catalyst Center for Consumer Engagement and Health Innovation, and supported through the Medicare-Medicaid Coordination Office, or MMCO, at CMS. MMCO is developing technical assistance and actionable tools based on successful innovations and care models, such as this webinar. To learn more about current efforts and resources, please visit our website or follow us on Twitter. Our Twitter handle is @integrate_care. We have a packed agenda, and I think you'll all take away some key learnings from each of our presenters, including strategies for supported decision-making so that members can make life decisions for themselves without undue or overboard guardianship, and shared decision-making, and goal setting, goal-driven planning, and goal attainment. And before I turn it over to our speakers, I'd like to field a quick poll so that we can better understand the audience and who's on the phone today. And here's the poll. Which of the following best describes your professional area? Healthcare administration, medicine, nursing, PA or other, pharmacy, social work, advocacy, health plan management staff. Go ahead and use your mouse to select a response. And I'll give it a couple seconds. It looks like we have a good showing from social work, about 20% of our audience from social work, and about 20%, and actually 26 is listed as other, and 20% as direct healthcare providers. So that's really helpful for us. Thank you for participating in the poll. It's nice for us to understand who our audience is for today's webinar. At this time, I'd like to introduce our speakers. We have Jonathan Martinez from the Burton Blatt Institute at Syracuse, Sandra Fernier from Neighborhood Health Plan of Rhode Island, Laura Sankey at Centene, Dr. Robert Schreiber at Hebrew Senior Life, and Janet Deneau. And I'm going to go ahead and turn it over to Jonathan to get us started.
Good afternoon, and thank you. My name is Jonathan Martinez. I'm with the Burton Blatt Institute. Very happy to be with you today to talk to you about supported decision-making. Can we go to the next slide, please? If you've heard of supported decision-making, you've no doubt heard about it as an alternative to guardianship, and we'll talk about that today. But I think we're also going to talk, and I hope you will see, that the use of supported decision-making can also improve people's life outcomes. It can be the keystone part of the service that is provided to people and what people receive from you. Next slide, please. So let's begin by talking about Jean-Paul Sartre. I'm sure that's a very familiar place for all of us to talk about when we talk about rights, but look at the quote on your screen. It makes perfect sense. We are all our choices. Each and every person listening to this webinar is here because of the choices they've made all their lives. The important ones, the silly ones, the significant ones, the bad ones. Our choices tell us who we want to be, who we don't want to be, and how we want to live our lives. In fact, if you think about it, every important right that you have comes down to the right to make choices. The right to free speech is the right to choose what to say. The right to vote is the right to choose our elected officials. Life, liberty, the pursuit of happiness is the right to choose the kind of life we live, the people we're with, and what we do. So this right to make choices is what makes us who we are. Next slide, please. Clinically, that's called self-determination. Self-determination is a fancy word used by professionals. It just means being in charge of your life. People who have self-determination are the captains of their ship. They do things rather than having things done to them. They are causal actors. Next slide, please. And what we know from 40 years of studies is that when older adults and people with disabilities have more self-determination, when they exercise their right to make choices, they have better lives. This is undeniable. 4 decades of research. People with disabilities and older adults who have more self-determination are more independent, healthier, more likely to be employed, and according to at least one survey, safer. Next slide, please. But what we've been doing for 2,000 years is we've been taking away the right to make choices from people, in some cases reflexively, by assuming that people cannot be in charge of their lives. Going back to ancient Rome 2,000 years ago, if you were what they called feeble-minded, you would have a curator put over you to make all your decisions. In the Middle Ages in Britain, if you were an idiot or a lunatic, in their words, you would have a committee put over you to make decisions for you. Next slide, please. We've continued this historical pattern in America through guardianship. Now, every state has its own guardianship law, so guardianship is a state-by-state thing, but the laws essentially come down to one thing. If a judge decides that person A cannot make some or all decisions in their lives, they give that power to person B. Person B becomes person A for all intents and purposes because, as studies have shown, the vast majority of guardianships are full or plenary and take away all of the rights of the person, regardless of their preferences or abilities. One law professor I know calls that type of guardianship a civil death, because the person under guardianship ceases to exist in a legal sense. That person cannot interact with society except through someone else. I refer to guardianships that are too broad or that people don't need as overbroad or undue, because they take away rights from people when people can exercise them. Next slide, please. And what we also know, just like that we know that self-determination leads to a good life, taking away people's rights to make choices leads to a worse life. Again, study after study have shown that when people lose their right to make choices, they feel helpless or hopeless. They're self-critical. Their ability to function decreases. In some cases, they are less healthy. Next slide. But at the same time, what we also know, and this is from as recent a study as last year, is that when people have the right to make choices, when they're in charge of their lives are better. On your screen right now is a summary of the National Core Indicators study. The NCI was an apples-to-apples study done in every state. I call it apples to apples because it reviewed the quality of life of people with intellectual and developmental disabilities viewing people in similar situations as others. In other words, they used the old standards, mild, moderate, and severe disabilities, and they compared people with mild disabilities to those with mild disabilities, moderate to moderate. And they looked at the quality of life of these people across a number of variables. One of the variables they reviewed was whether or not the person had a guardian. And looking at just that one variable, they found that people who did not have guardians were more likely to be employed, independent, have friends, date, and practice the religion of their choice than people who had guardians. So if we know this, if we know that this is true, that potentially the only thing standing in between having that kind of life and not having that kind of life is having a guardian, doesn't it mean that we need to be very careful about whether or not we put people under guardianship, that we should not do it reflexively? Next slide, please. Because I'm not here to say people should never be under guardianship. That is not my intent. But what I am here to say is that we need to be careful and find ways to maximize people's self-determination, because that has been found time after time to be the key to a good life. So what we need to do, I propose, is find a way to keep people in control of their lives to the maximum of their abilities, while at the same time recognizing that some people need more help than others. That's absolutely true. Those of you who deal directly with people with disabilities and older adults, the social workers out there, the healthcare providers, you know that as we age, we need more help, or that some people need more intensive types of help. So that's why I say we need to find ways to provide that help while keeping people in control of their lives. Next slide, please. And that is at the heart of supported decision-making, what I'm here to talk to you about. There's a big, long definition on your screen about supported decision-making. I wrote it. I don't like it. I mean, we can talk all day about how it's working with friends and family members and professionals to help people understand the situations and choices they face so they can make their own decisions. But, next slide, please, I'd much prefer to define it this way. How do you make decisions? What do you do when you go to the doctor and the doctor speaks jargon to you? Those of you who are doctors in the healthcare profession, Dr. Schreiber, I apologize, but it does happen from time to time. The doctor will say something like, you've got a subluxation in your cervical brachial area that can be treated conservatively with a course of anti-inflammatories, or aggressively with a surgical intervention. And I'll say something intelligent like, what? Can you explain that to me like a 5-year-old? And the doctor will say, you've got a crick in your neck. We can give you Motrin, or we can give you surgery. Then I understand, because I've been told in words I understand what my options are. When you go to the auto mechanic and they talk about things that you can't possibly understand, at least I don't, because I don't know about cars, and I call a friend and ask for advice. When I go to an accountant to help with my taxes, when I talk to a buddy for relationship advice, in all of those situations, I am practicing supported decision-making. I am getting the help I need to understand the situations and choices I face so I can make a good, informed decision. That's all supported decision-making is. Next slide, please. It's making decisions just like you and I do. The only difference is, if you're a person without disabilities, if you're me, if you're temporarily able-bodied, as one person calls it, doing that, using supported decision-making, saying I don't understand, is smart. You're considered to be wise and judicious. But for 2,000 years, if you're an older adult or person with disabilities and say, I don't understand, help me, what we've done is we've taken away rights. So across the country, as we see on your screen, we've had a change in position, a paradigm shift, at least I hope so, moving away toward reflexively taking away rights and more towards supporting people. We have laws in Texas and Delaware that recognize supported decision-making as a way to make decisions. The U.S. Administration on Community Living and the Department of Health and Human Services has funded a national resource center for supported decision-making that I'm honored to be the project director of. States like Virginia and Missouri and others are taking positions that it is better to support people than take away rights. The American Bar Association and the National Guardianship Association, the NGA, an organization made up of guardians, by guardians, for guardians, has taken the position that we should seek to support people before we seek guardianship. Next slide, please. And across the country, we're seeing active programs designed to do just that. In the Carolinas, in Nevada, in Maine, in New York, in Florida, in Idaho, we're seeing courts and people and agencies and entities coming together to use supported decision-making to help people become independent and stay independent rather than lose their rights. Next slide, please. And that's important, because we're not just talking about guardianship here. Think about the definition of supported decision-making, working with people to help them understand their options so they can make their own decisions. Those of you who do person-centered planning, doesn't that sound just like supported decision-making? Next slide, please. In person-centered planning, you're required to work with a person to understand his or her preferences so that the person can choose the best possible programs and services to help live their best possible life in the community. How can you do that except through supported decision-making? How can we have a student-led IEP in special education, which is best practices where the student sits at the head of the table surrounded by educational professionals, teachers, administrators, professionals, parents, and advocates with the goal that the student leads the meeting and the student defines his or her goals? Doesn't that sound like supported decision-making? How can we do informed choice in healthcare or in vocational rehabilitation, which is predicated on the professional providing information to the person so the person can make the best possible choice, unless we are using supported decision-making? So as I said at the beginning, supported decision-making permeates throughout the system. It is not only best practice, it is already required by our laws and regulations, as you see on your screen right now. I pulled that directly from CMS's website on what people should do to do person-centered planning. And I submit to you, it is a perfect definition of supported decision-making. Next slide, please. So what we can do next, knowing that supported decision-making permeates through the system, is use it as the common tongue to connect the supports and services that help older adults and people with disabilities, something that a partner of mine and I call the culture of coordinated support model. In the culture of coordinated support model, which would take more time than we have to describe in full, the whole idea is that agencies that use supported decision-making or should work together to implement supports and services. We should not have an employment provider in one corner, a Medicaid provider in another, a school in a third, without them speaking with each other and connecting. Think about the definition of person-centered planning. It is supposed to address education, employment, healthcare, finances, and future planning. Well, in the culture of coordinated support model, that provider is also collaborating and coordinating with other entities that do or could do the same thing. In that way, you each can share burdens and build on strengths so that you're not overloaded. To any of you who do person-centered planning, I've been around the country and I've heard the complaints. I know that it is impossible, or darn near it, to do all of the things that you're required to do by the settings rule and all of the things you're required to do under the person-centered planning rules without short-shrifting the person, without asking a series of checklist questions. Well, by using and working with others, by bringing other entities into the mix, you can now better meet your requirements, because if you are working, for example, with a vocational rehabilitation agency to take the lead in employment areas using supported decision-making to ascertain the person's preferences and goals, that's one less thing you have to do. You can simply say that you are aware that employment goals are being met and that you are regularly keeping track on how they're being met, which now allows you to focus more clearly on things like community integration. Next slide, please. And that's happening too. I am honored to be the chair and the facilitator of the first statewide task force that is designed to create a culture of coordinated support model in Vermont. We have pilot projects where people who would never before work together are collaborating there and building on their strengths to help people live better lives. Just one example. A service provider, a Medicaid service provider, is collaborating with the public guardian, two entities that had never worked together before, to identify people who are at risk of guardianship or who are currently under guardianship and identify what's missing from their lives, what services and supports could help them better organize their lives, better run their lives so that they can be in charge of their lives, and then working with a self-advocacy group to help the person choose what services he or she wants, and then bringing in attorneys so that when this process is in place, to create power of attorney forms or to help the person ask the court to let him out of guardianship because they have addressed the very things that put them in. In Vermont, we're working with Medicaid providers, schools, the Voc Rehab Administration in order to identify students who are at risk of guardianship and help them get the wraparound services from those three entities in a coordinated way that builds on the things each of them do well to help the student live the best possible life and get the services he or she needs to be independent and avoid guardianship. And we have a task force that meets regularly to discuss ideas and discuss new ways to collaborate so that no one entity feels like it has to go it alone. Social workers out there, I've heard people across the country say we feel like we're on an island. We're supposed to be bringing people in, but no one brings us in. This model puts people at the center, truly at the center of person-centered planning, and empowers you. It empowers each agency and each provider to better serve that person and also to coordinate services so that the person is better served and so that you can spend more time doing that which it is that you got into this field for in the first place. Not to fill out forms, not to check boxes, but to truly plan services and supports and create networks so that the people you work with live their best lives. Next slide, please. And that's where I want to end you. This quote on your screen is an article. It's from an article that I co-wrote with my partner that was published in Apostrophe magazine. What we propose is world-changing because for too long the system has been siloed. You've been on an island. People have been sent to different places to seek different types of supports, even though those supports are consistent with or like supports that can be provided in other places. The result has been what one expert calls a fragmented system of services that leads to the failure of people with disabilities to be able to become productive members of society, not because they lack an ability, but because we as a society fail to provide good supports and services because we're so busy sending people off in different directions that they spend so much time trying to figure out who can provide services that they never actually have the time to access good services. By creating coordinated, collaborative networks that have supported decision-making at their gut, which they're supposed to have under law right now, we create an ability to give people with disabilities the same options that people without disabilities have, the same abilities to have the same opportunities that people without disabilities have, the same opportunities to reap the same benefits of self-determination that people without disabilities have. And if we do that, if we change 2,000 years of culture that say people with disabilities cannot live independently to a new culture that says they can and we will work together to make it happen, then we'll change the world. Thank you very much for having me today. I'd like to turn it over to Sandra Fournier. It's been my honor.
Thank you, Jonathan. I'd like to take a second to thank you all for joining us in this very important discussion. I hope that you find this information helpful in your approaches to work with all individuals. Thank you. Let me start again. As Jonathan said, we all make decisions. We all have goals. Goals are composed of a lot of different things. Although many of us have identified something as a goal for ourselves, we don't always identify the objectives and the methodology that's incorporated into making our own goals or our attempts to reach that goal. If each of you think of a goal that you've made, some of them were achieved more easily than others. The next slide, please. Patient engagement is an increasingly important component in healthcare. The contribution of the patient highlights the skills and confidence that patients need to make informed decisions and be actively engaged in their health and well-being. There's a growing body of evidence showing that patients who are more activated have better health outcomes and care experiences. Evidence indicates that interventions that tailor support to the person's level of activation and that builds skills and confidence are effective in increasing patient activation. An activated patient is more fully engaged in achieving their goals. Some evidence indicates that patients who started at the lowest activation levels tend to increase the most. Next slide, please. It all comes down to meaningful engagement. The process of meaningful engagement results in engagement of the person. It allows them to express their goals, their expectations for care, and their level of involvement, and insists in helping the person to reach the established goals. Next slide, please. A person-centered approach is always necessary for this. A person-centered approach helps us to move from the need to protect and confine to a place in which we honor the person's concept of life. Our new role in this day and age is to help a person experience and explore and growth and development. Next slide, please. Person-centered thinking is where we need to be. Person-centered thinking serves to empower the person. It results in a service system that supports rather than controls individuals, and we enter into a partnership with the person. It promotes self-determination and interdependence and provides opportunities for people to make choices in their own lives, including where and with whom they live, who they have relationships with, the way they spend their time, the pursuit of their personal future, and program planning and implementation, which results in a choice of lifestyle options with the least possible control by others. Next slide, please. It's a process. Person-centered planning assists members and their families to build their capacities and capabilities. This planning effort is not a single event or meeting, but a series of discussions or interactions among the person, the family, the service coordinator, the team. It's a real partnership. Whatever your system is in your state, it involves everybody. The team will be comprised of different people according to who the individual trusts and who the person is involved with. The next slide, please. This process is not something, as I said earlier, it's not something that happens in one meeting. It's a series of steps. So now we need to look at how we're going to measure progress towards a goal that somebody needs. First, we need to make sure that we're on the same page with the person. As we said in the previous slides, the goals that are set are the goals of the person. They're not the goals of the team member or the members, as has happened too often in the past, when the team thinks what the team thinks the person needs, likes, or wants become what the person believes in, what they need, like, or want. Yet in reality, the person may not have been given the independent exploration, independent thought, or even a say in the question of what happens to them or what matters to them. Next slide, please. So it's a series of steps. After we identify things, we need to identify steps to get to the goal and the resources. We need to identify barriers and approaches, and we want to identify those early on because that's going to help us mitigate them ahead of time. We want to empower the person to implement the goal that will implement the plan that will achieve the goal. Next slide, please. So how do we discover what's important to the person? We help the person to explore their interests. What are they good at? What is their skill? What is their talent? The challenge for the future is to establish the person's goals as the norm. How do we help others to understand that although their goals for the person are important, the individual's goals for themselves is primary? The person is choosing their life based on his or her own life experiences which we may not have lived. Speaking from my experience as a nurse, too often as healthcare professionals, we impose our goals for the person and we don't recognize that the person's goals may be different. We tend to seek 100% of goals, and that just isn't always achievable or interesting to the person. Next slide, please. So when we talk about the future, setting goals often involves a team of people, as I had said. Those on the team should understand the person's history, their abilities, their preferences, the barriers they've encountered in the past, and the barriers that are foreseeable in the person's attempt to achieve the life they want. The team members should understand the concerns of the person in meeting the goals and the problem that perhaps the goals will then produce. As an example, let's take employment for a person with a disability. Common goal nationwide for many. The state that I live in is under a Department of Justice consent decree, actually, to get people employed. And it's well achieved by many, but for some, The increased income can result in a loss of benefits if the planning isn't done correctly. Because of that, some individuals with a disability are unwilling to work or unwilling to achieve success at work. The realization is that you need to examine the person's past and life circumstances to determine the path to the future. Give the person credit for what they've accomplished despite barriers and what those barriers have prevented in the past. It's a real challenge in goal setting because every person has different life experiences, and often we have little to no real experience with many of the challenges presented to the individuals. Next slide, please. The planning process helps us identify potential barriers to the goals and helps identify strategies to address the barriers before they inhibit progress. We can't move forward if we're restricted by the barriers and the different hurdles that need to be jumped over. Sometimes we need to find a way around or between those barriers. Next slide, please. So as we move on to measuring those goals, achieving a goal can often be a daunting experience. Depending on our own unique life circumstances, we each define success differently. Goal attainment doesn't have to be an all or nothing measurement. It's not always 100%. Scaling success toward reaching a goal allows a person to move forward in increments. Next slide, please. By measuring increments to achieving the goal, an individual can move forward in a steady pace. A setback can occur in achieving the next step, but there's still success to be realized in achieving the previous effort. It becomes easier to recognize success versus realizing defeat. Next slide, please. Person-centered planning and goal setting is a realistic way to improve patient engagement and activation. By recognizing what is important to the person, we can help individuals to succeed in efforts to improve their health, their independence, and their overall quality of life. Next slide, please. I'm going to give you an example of person-centered goals, an approach that we use at Neighborhood Health Plan. We always start with an assessment of the person, and often it also involves team members if an individual has some difficulty communicating or isn't comfortable with, discussing goals with a stranger. A care plan is developed and the goal setting is done with the person, not done just with the team. Care plans with goals are sent to the interdisciplinary team, which results in one care plan, and the person has the major influence on developing that goal. Assessing, we repeat assessments from 3 to 12 months depending on the classification of the service level the person needs, as well as following hospitalizations. We maintain telephone contact with the person, and we incorporate the use of other available resources, such as a community outreach specialist, housing specialist, physical therapy, occupational therapy, some DME specialists, and as well as looking at home modifications. All of these things can either enhance or impede goal attainment. Next slide, please. So some key takeaways that I hope you can come away from this with are setting goals is essential to engaging individuals in their own care. An activated patient is more engaged in achieving their goals. Goal setting is a deliberate, ongoing process. It has to happen with the individual. And measuring goal attainment can be accomplished by percentages and by pieces. It doesn't have to be an all or nothing type approach to goal setting. I'd like to thank you all. At this point, I'd like to turn the presentation over to Laura.
Thank you, Sandra. Good morning, and thank you for having me today. So today we're talking about person-centered planning, and I was asked to provide a bit of color commentary on how this concept actually plays out in one of our managed care markets. Next slide, please. Next slide. There we go. So just as a bit of background and to level set, Centene is a managed care organization serving over 11 million members in 24 states. Today I'm going to be focusing on our Michigan plan, Fidelis Secure Care, currently being rebranded as Michigan Complete Health.
Fidelis participates in the financial alignment demonstration and operates a Medicare-Medicaid plan, or MMP, in Wayne and Macomb counties. They, in turn, partner with Concerto Health, who operates 4 clinics in those regions and delivers care management and primary care services to Fidelis members. So on the previous slide, we were seeing our agenda. So today, we're going to focus on this Fidelis Concerto model of care and how it supports person-centered planning. We're going to also discuss our approach to identify what matters most to our members and describe how we use that information to motivate and engage our members in order to achieve their own person-centered goals. Next slide, please. So as I mentioned, Concerto operates as a delegated entity for Fidelis. So they perform the Level 1 health risk assessments and coordinate the care for Fidelis members. The actual physicians on staff there at Concerto serve as PCPs for over half of the Fidelis members. So they see them in the clinic as well as in the community when appropriate. The clinics are located in close proximity to the population served. There's apartment buildings in nearby Detroit who house mainly dual-eligible beneficiaries. And so the clinic's really in walking distance for many of those members, which is certainly helpful. The clinics themselves are disability competent and were designed with the member in mind. They're built on flat parking lots where the clinics have 0 steps. They've got wide doorways. They've got these really great adjustable exam room chairs and tables for the frail and elderly in which they can kind of sit down, and instead of climbing onto an exam table, they sit down and it just kind of tilts back, which is kind of a nice feature. They've got wheelchair accessible scales. They've got a reflection room for spiritual contemplation and sensitive discussions. And they've got a health education room where classes are offered on topics such as diabetes and cardiovascular care. So that clinic really becomes the hub for that member's care coordination. And it really encourages that cross-collaboration between the staff members, including the care managers who coordinate with the area agencies on aging and the prepaid inpatient health plans, or PIHPs, who handle that behavioral health component. Of course, the PCPs are there. You've got the pharmacist who performs the medication reconciliation. You've got a dietitian on board. You've got an LTSS coordinator who can work with those AAAs. And then you've got a disease management educator. So all of them are able to kind of come together in that one setting to really support that member holistically when needed. Next slide, please. There you go. So while the clinic certainly lays out the design to support that member, it's really that person-centered training that makes that really impactful. So at an enterprise level, Centene's put a lot of effort into building out our member engagement and person-centered training modules over the last 12 months. Our Texas Health Plan worked with Susan Fegan from the Institute of Person-Centered Practices to develop a 3-day program, really focusing on what it means to be person-centered, and we're in the process of rolling that out to our plans, including Fidelis. So in addition to kind of focusing on that person-centered care planning, the course actually goes even deeper and covers things, foundational topics really like disability rights, guardianship alternatives, cultural competency, person-first language, communication styles, and active listening techniques. Motivational interviewing is also included in that training. Those methods are then, of course, shared with care managers to assist them in gathering the member values and preferences. So, of course, by asking probing questions and digging deeper into what the member really wants and values, we're really able to start kind of collaborating within that interdisciplinary care team and develop care plans that meet the needs of that member and that are really based on best available evidence. In addition to the Centene curriculum, Fidelis participates in state-provided train-the-trainer offerings, including person-centered planning and self-determination. And while all of this is certainly appropriate for our care managers to understand those concepts, we also ensure that other departments across the organization are educated as well to really truly create that culture of person-centeredness that permeates across the enterprise. So these teams go through MMP product trainings that really reflect on the overarching goals of the program and outline the importance of member choice regardless of physical or mental ability. Teams like the provider networks or our member connections, which is like our community health workers, or our marketing teams really start to reframe what they do with those concepts in mind, and they start to promulgate the importance of choice when communicating with their stakeholders. So that culture really starts to shift from telling somebody what they need to do, and then, of course, moves towards providing members with options and allowing them to choose what the best decision is for themselves. Next slide, please. So at Centene, we define the person-centered life plan as a process that guides exploration of and action on a member's wants, needs, and goals, resulting in a balanced life plan which allows the member choice over their own care and to live a satisfying life in their own community. So we really believe in, instead of asking what's the matter with you, we really need to start asking what matters to you. Next slide. Finding out what matters to a person is key. It's really about asking a member what's most valuable to them, asking them what makes them happy or excited, what makes them feel satisfied or fulfilled, what do they want in their life, what hopes and dreams do they have, or what routines do they prefer. We also need to consider what's important not to be in a member's life. Finding out what needs to be absent can help create a care plan that lessens the amount of stress a member has and really shows the member that we're truly listening to them. So determining what's important to a member and helping them achieve it really starts to build that trust and contributes to better outcomes. Next slide. In addition to asking a member what's important to them, we certainly need to be identifying what's important for them. And we're usually pretty good at this already. Our nurses, our care managers, our service coordinators know how to put those services in place and keep a member healthy and safe. They provide information on medical and behavioral health diagnoses. They educate members on preventive measures. They really ensure that they've got the equipment and the services needed to remain safely in their homes. So we work with our members to ensure that they've got a sense of well-being, and of course, that means that we not only are able to report suspicions of abuse, neglect, or exploitation, but we educate the member on what that is and how to get help if needed. Another important part of Important 4 is the need to feel valued. And so if a person doesn't feel valued, it can certainly affect their physical, behavioral, and emotional status. So when a person feels as if they've got no value, there's little left to live for. So it's really important for a member to feel valued and to make that valuable contribution within the community. Next slide. So here's some examples of some important 2 and 4 questions that we consider when working with our members. By asking important 2 questions like how do you want to spend your day or where do you want to live, and recognizing that the member's got the right to make important 4 choices such as who are your providers or what treatments do you wish to pursue or not pursue, then we're able to develop that truly person-centered plan because we've identified that nobody really wants to do important for them unless it satisfies something that's important to them. Next slide. How do you achieve that balance? And that really becomes the secret sauce of successful patient engagement. And so it's really the role of our care managers to simply help guide that member through that process, including anyone that they want to include as part of their team. We have to remember that it's all about the member, and it's that member's driving force for any person-centered life plan. Next slide. How does this play out within the Fidelis Concerto model? In Michigan, the care plan is called the Individual Integrated Care and Supports Plan, or IICSP. It includes all the items noted here, as well as the member's preferences for care, services, and supports. It also prioritizes their list of concerns, goals, and objectives. So as members make appointments to come into the clinic, the staff prints off the care plan, usually the day before the visit. This allows the PCP to review the information and prepare for that visit. The PCP also uses a system called P360, which houses pharmacy data, claims data, identifies any care gaps that the member might have. It houses the care management notes from conversations in the past, and it also includes the member's electronic health record. So all of this information is available to that PCP to holistically look at that member in preparation for their visit the next day. Next slide. At the time of the initial assessment and at subsequent reassessments, the member is asked about their desired level of participation on the interdisciplinary care team and who else that they want to have on that team. The ICT can include family caregivers, a variety of providers, pharmacy staff, as well as clergymen, any others as appropriate and as requested by the member. So for members utilizing Concerto PCPs, this of course becomes a little bit easier as many of those ICT members are located within the clinic. Remember I said there was over 50% of the Fidelis members are assigned to PCPs at the clinic themselves. So that becomes very easy to kind of start to collaborate within some of those, the ICT members in the clinic themselves. But of course for community physicians it becomes a little bit more difficult. So it's the role of that care manager to really quarterback that collaboration and engage those external providers based on the request of the members and include them in that ICT conversation. Next slide. Another unique feature of the Michigan Duals demonstration is its use of the Care Bridge. So the Care Bridge is the Michigan technology solution to house information about the member. The Integrated Care Bridge Record, or ICBR, is the individualized member record and allows secure access for members as well as those that are on the ITT to use and where appropriate update information. Obviously, that care bridge becomes even more important for those community-based providers outside of that Concerto model, and it's up to that care manager to educate them about the care bridge and make sure that they understand how to use that tool for collaboration. So this really becomes the electronic hub of all information around that member, so that it really draws people towards that collaborative effort of sharing information back and forth and keeps people informed about what's going on with that member. Next slide, please. We understand the importance of supportive decision-making and allowing those individuals to really make their own decisions and stay in charge of their own lives while receiving any support they need to do so. Concerto staff are able to explain the program services and healthcare options to those Fidelis members. The information is presented in a culturally appropriate manner. It takes into consideration, the member's condition and the ability to understand the information. And so, of course, those with limited cognitive ability who might have chosen a designated representative or a supporter, we ensure that that supporter knows that they can help a member understand their options, their responsibilities, and the consequences of those decisions. They can certainly help them obtain and understand information relevant to that decision. They can even help them communicate their decision to the appropriate people, but they can't make the decision for the person with the disability. It's very important to kind of understand all of that support that goes into giving that person information to make that decision and not assuming that decision for them. Next slide, please. So members are also informed of the option to self-direct their own services. Our LTSS coordinator explains that choice to self-direct when the care plan is created and updated. That process is strictly voluntary, and so the member can consider the various arrangements and choose the extent to which they want to self-direct their services. That LTSS coordinator is available to help them and help inform them, navigate them, tell them what's available, connect them, and refer them as the member requests. Next slide, please. So one of my favorite parts of the monthly contract management team meetings that we have with CMS, the state, and the health plans is the sharing of success stories. Each is obviously unique in their own way, but they're all really heartwarming stories demonstrating improved quality and quality of life for our members, and certainly person-centered life planning is at the core of those success stories. So in this example, our member had been discharged from the hospital, was adamant that she didn't want to live in a nursing home, and due to that close relationship that the family had with Concerto and their care coordinator, the daughter contacted the care coordinator within hours of her mother's arrival back home to report changes in her condition. Her mother was, agitated and upset. So as the care coordinator really reassessed that member, she was asking, of course, what was important to the member. So she said, her husband was the most important thing to her, and that she didn't want to leave him home alone in the home that they had shared for 48 years. So the review was completed, and from there the care manager had her marching orders. She knew what was important to the member and what that person-centered goal was, basically to remain independent at home with her husband. So the coordinator took steps to get the additional LTSS assessments performed, and once approved, began assisting the member in getting those supportive services needed to remain in the home with her husband. Shortly thereafter, the daughter brought her mother back into the clinic for a follow-up visit and had tears in her eyes and said, no one in her whole life has helped them like, Concerto and the care manager had helped them, that getting all of those services, for her mother had helped keep her parents together in the house that they lived in for 48 years. So to me, this is just one example of many that I hear about that demonstrates what that person-centered culture of care is all about. It's listening to the member's wants and needs, providing them with some options, and then allowing the member to make their own personal choice. Next slide, please. So our key takeaways today are to recognize the importance of staff training on person-centered care. We need to put in the time and effort to ensure our teams understand why it's so important. And as I mentioned, our approach is to make sure various departments have that understanding, that it's not just about care coordinators. We need to encourage our care teams to ask those probing and thoughtful questions and really drive to what is important to the member in order to impact what's important for the member. And finally, care team members need to be educated and able to inform members of those care choices available to them through that supported decision-making and self-determination options where appropriate. So with that, I thank you for your time today, and I will hand it off to Robert.
Thank you, Laura. So I'm going to take supported decision-making and goal-driven care and apply it to older adults. Next slide, please. So we're going to provide an overview of a program that actually does this called Vitalize 360 and explain how Vitalize 360 can be used with beneficiaries in all different types of settings. And then we're going to provide a member perspective through Janet's story. Janet's here with me, and we're going to have a conversation, but specifically focusing on how providers worked with her to understand her goals and values and then guided her care plan and how that's been different than what she had been used to. Next slide, please. So in full disclosure, I am the medical director of the Vitalize 360 program. This is a program that uses a coaching and assessment system that combines an innovative and person-directed approach to wellness coaching with the power of information derived from a scientifically grounded assessment system. The program engages, challenges, and inspires individuals to live a full, healthy, vibrant life and enables communities to demonstrate appreciable improvements in successful aging. The program is now being done in approximately 34 communities across the country, including supportive housing where Medicare, Medicaid, and duals populations live, as well as people with disabilities. We also have this program in CCRCs and then CCR community, continuing care retirement communities, and community care retirement communities at home. We also are now piloting this in community centers and senior centers. Next slide, please. So the core components of Vitalize 360 are the following. First, the importance of resident engagement. And we've heard about the importance of engaging and understanding what people need, but getting them activated has been a real challenge. And this is something that the health system has not in the past been paying attention to. Sandy brought this up in particular, how the health plan has really put this front and center. Secondly, we have a meaningful conversation. Yes, it's a conversation. It's not an assessment, although an assessment is done with the individual and a senior coach. And it's done in a manner that allows for data collection and documenting the issues that come up in the discussion. Thirdly, we discuss take what we discuss and put it into assessments and software. We have a software program that's been developed specifically geared to what the individuals and coaches want to see and to help them make decisions. There are 2 validated assessments that are done, and this was developed by enrollee, which is an international collaborative to improve the quality of life of vulnerable persons using a comprehensive assessment system. So there are 2 particular assessments we use. One is called a lifestyle survey, which is self-administered and subjective. And then there's the health and social checkup, which is more objective, health-focused, and identifies potential risks that may require support and is done by the senior coach. The responses, as I said, are entered into the software, which allows for tracking of health outcomes for the individual as well as a population over time, and then it allows for us to assess how we're doing for the goals of the individual and population. Next slide, please. So another way of looking at this is that older adults are the CEO of their health and wellness. We heard from Jonathan about people being the captains of their ship, same type of concept. And sort of the way of looking at this is, imagine you had a community where people were walking around with a placard on the front and back where what really mattered to them was listed. And so your objective when you interact with individuals and each other is to help people achieve that goal. So setting meaningful, relevant, and impassioned goals is what this program's about. And with the goal of, one of the goals of maintaining a fulfilling purpose in life. We do this by empowering people to reach those goals and reach their full potential and to achieve the best possible life. Again, a lot of the same concepts that we've heard before. Next slide. So Vitalize 360 is really about changing culture. It's a different way of doing things. And specifically, we want to maximize a person's potential for vitality And by doing that, we're going to reduce healthcare costs. We're going to improve the value of the care they're being given, or the services or supports that they have. This improves population health and really lends to sustaining individuals in a sustainable way in their later years of life. Next slide, please. So what I'd like to do is take you through the process, this actual process. At first, we have an appointment where the coach, the senior coach, invites the individual to come meet, and they have a discussion and an assessment is done. A reflection and a worksheet is given where individuals are given some homework to go home and talk about and think about what it is that's really been important in their lives, what have been some of the barriers, what are some of the things they really want to achieve. After that, the individual, as they're doing their work, the coach is actually talking to others that may work with this individual. Again, we get permission to do this, to see what their reflections are. So the coach does some homework, the individual does some homework, and then they come back at a second appointment. This is where there's development of a resident's personal goals, an action plan. And this is really based on what matters most to the individual. They develop, and we'll talk a little bit more about this. In addition, we use the output from the assessment to inform the individual of some opportunities based on what they want to do, what they want to achieve, and what matters, of areas that they may need support on, and we ask them, what do they want to focus on? What do they want to do? After that plan gets established, we share the plan, and when we say we get permission to share the plan with people if they were living in a community, an interdisciplinary team, and this could be anything from a social worker, a home care coordinator, it could be somebody in who's helping with housing, but whoever the team is, to really share what the individual's goal is and what they're trying to achieve. The individual also can take that life care plan and their life goal or their goals and bring this to their healthcare provider and also to their family members to really talk about what it is that matters most. And after that, the resident receives ongoing support. The coach will check in with them quarterly, as well as people on the team will be checking in with them to see how the individual is managing and reaching, or what is challenging to them in meeting their goals. And then on a yearly basis, the resident comes back. We see if they achieve their goals, and if they're not attained, do they need to be revised, or do new goals need to be developed? So that's sort of the process. Next slide, please. I want to talk a little bit about this vitality plan. So the fact of focusing on what matters most in older adults, many times they are living and doing, but not thinking about what it is that's really important. This gives them a chance to really identify what it is their values, strengths, and accomplishments are, and determine whether or not they want to pursue other goals, or do they want to do things that they maybe didn't have a chance to do in their younger life that were really important to them. And based on that goal, it forms a foundation for a plan. I want to focus on this because it's different than what we've been hearing, in the sense it's not really a medical care plan. This is a life care plan, a vitality plan. Most people spend the majority of their time outside the health system. How do they want to spend that time based on what matters most? So the goals that individuals reach for have to be sort of realistic, and that's where the coach works with them. Sometimes they're very big, hairy, audacious goals. Other times it may be something just connecting more with their family, but there are specific action steps that informs those decisions. And there is a summary report that comes out based on the assessment that helps the coach and the individual reach those decisions on where they're going to focus. Next slide, please. So there are 5 health-related values or domains that occur on this. One is functioning. An older adult's functioning is what is most important, because if you can't function, you can't do the things that really matter to you. We also focus on health and wellness, how they need to take active charge in taking care of their chronic issues and what they can do in terms of behaviorally to improve their health. Connections with others are very important. Life enjoyment and pleasure, having fun is another piece that we focus on, and then really engagement and a sense of purpose. So this is what comes out of this approach, and people are able to achieve various aspects of these 5 domains. Next. So we have outcome reports on the individual, community, and population level. There are 9 primary indicators gathered through these measurement tools, as I talked about, and then there's a risk-adjusted score to compare populations. The 9 primary indicators include outcome reports that are involving mood, cognition, social life, satisfaction with life, ED or hospital use, physical activity, community engagement, falls, and pain. And after we do that, you'll see in the next slide, there's a composite score, and I'll show you that in a second. These reports can be used for a variety of purposes. It can be used by clinicians and administrators to actually look at what's happening with their population over time and benchmark their population's health with their peers in the hope of identifying best opportunities of improving care. In addition, individuals can see what's happening to themselves over time, and this will allow them to develop an action plan and just determine whether their goals need to stay where they are. Next slide, please. So when we take those 9 indicators, we then roll them up and we put them into a composite score. This is sort of a report card, and we have 3 reference points: a 20th percentile reference point, a 50th median, and an 80th percentile. Now, these scores can be done in assisted living populations, even in nursing home populations. We can actually make certain that we call those populations out and compare them, but in fact, this can be done across all different populations. And this gives us a summary score of how a population is doing. So again, they're risk adjusted. That allows for comparisons between many different sites. Next slide, please. So I want to, before we turn this over to Janet, to give you some key takeaways. We need to have a patient engagement strategy that is holistic and that really focuses on what matters most rather than what is the matter with the individual. Medical providers need to help individuals make healthcare decisions based on their goals and values, but specifically really what is important in their life, as well as what's important and involved in their health care. And this shared decision-making is a natural byproduct of this approach, where we actually have people working together to help support each other in the sense of we can work to help you achieve your goal, and by you working with us, we can make our community, our organization better. So with that, I'm going to turn it over to Janet to share her story. Welcome, Janet.
Thank you, Rob. This is my first year in participating in the Vitalize 360 program. But even though I'm new to the program, I can already tell that I've got a better understanding of what matters most to me at this point in my life and why. As a result of my conversations with my coach and going through the steps that Rob outlined, it's become clearer to me that not only is it important for me to do what I can to maintain my health and stay active so that I can have a satisfying life for as long as possible, but it is equally important to me to be able to control and be actively engaged in determining what happens to me in the different types of areas that affect the quality of my daily living. as a result of my discussions, I've developed a couple of goals. One of them is to refocus on things that I had been doing a year ago to regain the energy and feeling of well-being that I had had when I was regularly exercising along with eating a balanced diet and avoiding foods that trigger my sensitivities. I've discovered that this makes a big difference in how much I enjoy life and what I experience on a day-to-day basis. I was pleasantly surprised that when I met with my gerontologist at Hebrew Senior Life that they were already aware that I was engaged in this pursuit, and it had included it in a discussion during my first appointment. One of my other goals is to look to the future and start now to build working relationships that I can really trust and rely on to represent what's important to me when I am no longer able to advocate for myself. This is one of the things about the Vitality 360 program that is very different than the experiences that I had for about 20 years when I was trying to support my mother and ensure that her life satisfaction was included in the decision-making related to not only where she lived, but the types of activities that she received support to participate in. So far, I'm very pleased with my experience with the Vitality 360 program, and I'm looking forward to working in that structure to ensure that I feel that I will be represented in the future as I age.
So Janet, that's really very interesting, and there was a couple of things that you mentioned that I wonder if you can sort of give us a little bit more information about. In particular, you mentioned just in the last point about your values and goals and how that's important not only to have people understand them, but to use that as a springboard of moving forward. Can you talk more about why that's so important to you and why you feel that that needs to happen and doesn't usually happen in the care delivery as we know it? So I'd be interested in hearing more.
For me, sometimes the devil is in the details. I know that what I see out of my window in the morning is important to how I live my day. And it's not something that is usually thought about in providing care, but as I age, that may be one of the primary ways that I get satisfaction from my daily life. In fact, I actually made a decision to select my new living space based primarily on that factor. And I can report that for every day since I've moved into that space, I look out the window and my mood shifts.
So this is really fascinating as you bring this up. Your values and goals are a way of determining how you want to live in the future.
Right.
What really is important, and to the point of even just where you live, the environment you live, and having active choices of what you want and what you don't want.
That is correct.
That is correct. And have you thought about this prior to doing this program? I mean, had anybody ever stimulated you to think about this type of approach in the past?
Nobody has stimulated me to think about this approach, but based upon the presentations today, one of the things that I realized is that I had been creating a person-centered approach when I became an advocate for my mother, and she was no longer able to advocate for herself. So the healthcare system hasn't been supportive of that. And I found that for a person that I loved and was concerned about, it was important that life satisfaction be included.
Yes, well said. All right, so thank you, Janet. That has been really very informative to me, and that fact of understanding what is important to you and how you want to live. And I think that probably relates to a lot of our discussion today. And I'll turn this back over to Karen because I'm sure there's going to be a number of questions that have been stimulated today. Thank you.
Wonderful. Thank you so much to Jonathan, Sandra, Laura, Rob, and Janet. Thank you for those presentations. We learned about creating a culture of coordinated supports, shared and supported decision-making and goal setting, and we heard some great concrete examples of these concepts in action. And this last interaction we just heard between Rob and Janet, I think, was a really great example of the interaction and dialogue for elucidating goals, making active choices, and understanding what matters most to a patient. So this has been really informative. We now have some time for questions from the audience, and we did see a couple of them come through in the chat window. So go ahead, if you have questions, type them into the chat. And I have one that I'll start off with. I think any of our speakers can probably answer this actually, but Rob, and you may have referenced some of this during your presentation. What validated tools do you use in assessments to determine an individual's strengths and capabilities?
So that's a really great question. So in terms of the approach, we have a tool that we use. It has not been validated. It's more of a tool that's a reflection sheet in terms of having individuals, again, go through their life, experiences, and as Janet just had even mentioned, what were the things that gave her pleasure and joy, and is that something that she wanted to continue? So in terms of the approach, it's more of an approach to get to a goal, and in terms of the validation, it's really having a conversation where we ask individuals to reflect. The validated process is a senior coaching process or a coaching and reflection process. So there is actual certification for individuals to actually learn this approach. But the worksheet we had was really predicated on the feedback we had gotten from our members as we piloted this, and this has been a work in progress for about 7 years now, and we then refined it. But the coaching process and the listening, there are evidence-based approaches, and there are certifications. So I hope that answers the question.
Great, thank you, Rob. And I have a series of follow-up questions for Laura based on on the examples that you've given. Laura, how many of your clients with complex care program have intellectual and developmental disabilities? Do you have an answer to that?
I don't have that breakdown in front of me. I do have the breakdown of specifically for our Michigan market, how many we have as institutional waiver versus community, if that might be helpful to the person inquiring. So for Michigan, we've got 4% that are institutional, we've got 9% that are considered waiver, and then we've got 88% that are community-based, our community wells in that market.
Thank you. And then specific to the success story that you shared, how would you have helped that member if they didn't have the resources to allow them to stay at home with their spouse? So in other words, if they didn't have the funds for private care or needed skilled nursing facility.
Sure. As part of that MMP program, we've got those waiver services, and so part of that example was a matter of getting that member to go through the additional steps of going through the LTSS waiver assessment to see if they qualified for that particular part of the benefit. And in this case, they did, and so that's picked up on the Medicaid side of that benefit of the program. So these are all full duals that are in this program.
And then is CareBridge a Centene product?
CareBridge is specific to the state of Michigan. It was state-driven. So that's their version of it. In South Carolina, we've got something similar called the Phoenix system. So it's driven by the state. And so all of our managed care organizations in this program in the Michigan market are using that care bridge. So it's not specific to Centene.
Thank you, Laura. And I have a question for Janet. This is also a follow-up question to something you said earlier. Do you feel that the healthcare system hasn't known how to, or is it more that people are scared to talk about aging, health issues, and all that is associated with end-of-life planning?
I think that the healthcare system is operating within a set of assumptions that constrain what's available to an individual. I've been fairly healthy to this point in my life. So if I look at the aging process and what's needed as people's capabilities decline, I rely on, as I indicated, my experience with being an advocate for my mother. And she received very good medical care. And I was included in medical discussions. Where I had difficulty was being able to be heard and to put resources in place that were truly critical to how she experienced her life day to day. And it wasn't my opinion of what I thought she needed. I could tell by the glint in her eye and the smile on her face when things were working for her and when they weren't. And I'm pleased to say that by and large, she was able to live a happy life to almost 100 years old.
Got it. And this is a question for all our speakers. How do you balance independence and safety in people who have cognitive impairments?
I can jump in on that one because I get that question a lot. This is Jonathan. That often comes up when people ask me, if you engage in supported decision-making, how can you guarantee that people won't make bad decisions, or how can you guarantee that people won't get taken advantage of? And I always answer it this way: I can't, and I won't. In fact, I guarantee you that people are being taken advantage of who use supported decision-making in the same way that I guarantee you that people without cognitive impairments are being taken advantage of or led astray by people they trust. The comeback, though, is that there's never been a study, ever, that has shown that people under guardianship who lose their right to make decisions are inherently safer than those outside of guardianship, never one. And there have been numerous stories of people who've been subjected to abuse within guardianship, who've lost their rights and still been led astray. So if we are looking at two options, losing rights or not losing rights, each of which can result in people being hurt, the one I'm going to at least try first is the one that is correlated with increases in self-determination, because self-determination has itself been correlated by research with increases in safety. That's not to guarantee that people will be safe. You can never do that. But at a minimum, we can attempt to empower independence, which itself has been correlated with safety, at least as a first step. None of us are inherently safe ever. All of us can be made more safe, and research suggests that those of us who are more self-determined are safer.
And if I could add, this is Sandy, one of the takeaways that, yes, it is a difficult decision when there is risk involved and we don't know if the person really understands the risk, but that becomes part of where our service to the person, it takes on an added importance, is what techniques are we using to educate the person about risk, and what type of risks are we identifying for the person, and how do we relate that to the person? How does the person relate to that? It becomes very much a challenge, but it's a challenge that, if we do things correctly, we are educating the person, and through self-empowerment and education, they're able to make better judgment calls.
And this is Rob. I don't know if Laura wants to go too, but I am a geriatrician, and it's a great question. I'm going to take it more from the medical perspective, from a gerontologic, holistic perspective. And this really comes down to the autonomy of the individual based on their values and goals. And I have many individuals who have cognitive impairment that are very clear about how they want to live, where they want to live, and as the dementia progresses, those values and goals usually do not change. And so we are taking risk a lot with individuals, but it's documented, the family is involved, we have, we do have to report this sometimes to Elder Protective Services, they're aware, but oftentimes we're able to support people even into advanced dementia, at which point then we oftentimes have to activate the healthcare proxy, but the healthcare proxy, not get to guardianship, as Jonathan was talking about, we keep that in place, but that proxy is there to really help that individual live their least restrictive life based on their values and goals. And in general, many people, even though there may be bad outcomes, and there's no way we can't guarantee they're not going to fracture a wrist or a hip, because that does happen, but more times than not, they're able to live and die in their home rather than have to have their their rights and their values and goals sort of abrogated. And so it is risk, but having those open conversations and understanding what matters most in documenting it, you do not get into medical legal trouble. And if in fact what happens is the family and the patient, their satisfaction and their care experience oftentimes is highly rated.
And this is Laura. I would just kind of add to that. So part of our focus too is, as part of person-centered planning and member engagement, is really engaging that family. And so a great portion of our membership is frail and elderly. And so as we recognize the patterns that start to emerge, we tend to try and wrap in those family supports and creating a caregiver program that allows people to see, what is this disease progression, where are we going with this, and the sooner you can identify those folks and start to have those conversations much earlier, you can start to document those preferences so as things do progress, we've already had those conversations and it's not too late.
Thank you all. I have a question from Andrew, who's a social worker, that I'm going to read off and wanted to get everyone's reactions to. So Andrew says, as a social worker, I appreciate this approach to client-patient care. Having said this, my concern is that the client needs guardianship services may fall through the cracks for funding and assessment reasons if there's a push towards this approach over recognizing truly impairing physical and mental deficits. So in California, this is already happening. It's becoming increasingly difficult to access guardianships for clients appropriate for this service. Reactions to that?
Okay, I can respond to that this way. I led my presentation today, and I maintain I am not here to say that there should never be a guardianship. I am here to say that we must be very careful before we take rights away. And I think we must do what the state laws say. California's state law, for example, talks about guardianship being the least restrictive, conservatorship they call it out there, that things like that shouldn't happen if there are less restrictive options available. So shouldn't we explore options first? If a person truly is impaired to the point where he or she can't make decisions and there's nothing else that can help, then of course conservatorship in California, guardianship in other places is appropriate. What I'm suggesting, I think I've heard the other panelists say, is that we should not rush to that because the rights at stake, autonomy, self-determination, and the positive life outcomes with which they are associated are so important that they should not be cast away before we try to empower them by other means.
This is Rob. I'm just going to echo what Jonathan said. In my experience, and I deal with highly complex, frail, older adults with multiple morbidities, many of which have dementia. And it is very rare that we have to pursue guardianship. As a matter of fact, I would say over the last 4 years, I've had 3 of them. Oftentimes, we can work with family, community supports to actually keep the individual, their goals and values up front. We oftentimes will activate healthcare proxies, but if we have a family that's supportive or a friend that, knows the individual, oftentimes we're able to maintain that self-determination and autonomy without having to go for conservatorship. So my sense is, I know the funding streams are, decreasing all over, but my sense with, and I agree with Jonathan, this is not to say it won't ever happen, but I think that the number of conservatorships can be dramatically cut down if we truly have a patient-centered, value, goal-driven approach.
Mm-hmm. Thank you. And I think we have time for one last question, and we might take this offline as well, but are there specific research articles that speak to guardianship being related to poor quality of life?
Could you repeat the question, please?
Can you repeat that?
Are there specific research articles that associate guardianship with poorer quality of life?
I know of no article that has associated with guardianship with improved or worsened quality of life, and I think that makes sense because guardianship is nothing more or less than a legal construct. It's what happens with the guardianship. It's, there are guardianships in state laws, and I can cite several of them, that say the guardian is supposed to involve the ward in as many decisions as possible and maximize his or her self-determination. If we view guardianship in that light, and we view guardianship as moving toward the person being more independent, then it can be a facet of supported decision-making. What the research says is that when people lose their rights, when they are denied the opportunity to be part of their decision-making and have their lives well, that's correlated with worse life outcomes. The problem is that too often guardianship is equated with that, where guardians feel that their role is to make all decisions for the person. So it's not that guardianship is equated with a worse life. Its loss of self-determination is equated with a worse life, and I can cite you chapter and verse on that.
Thank you, Jonathan. At this time, I think we will probably close this presentation. It's been really informative, and there's been a high level of engagement from the audience. Any questions we did not have time to address will be posted on our website in the form Q&A. I think we addressed all of them but one about the PAM, so we can reach out and ask that and get any of those questions posted. But if you have additional questions or comments, you can email us at ric@lewin.com. And the slides for today's presentation, a recording and the transcript will be available on our website as well. And a huge, huge thank you to all our speakers, and thank you to everyone for attending and participating.